So we're just going to talk a little bit more about the anaesthesia itself, which I know is probably the bit you're all most interested in. In terms of anaesthesia in the trauma patients, in our emergency patients of all nature, the ultimate aims of anaesthesia are exactly the same as any other patient. They can just be a little bit harder to achieve. So we're wanting our unconscious patient, we're wanting muscle relaxation, we're wanting analgesia. The big thing is it's going to be a lot harder for us to maintain cardiac output, to optimise tissue perfusion and maintain oxygen delivery in these guys who are systemically unwell. And that is why stabilisation is key. The more we can stabilise, the better, the more stable our patient going into the anaesthetic, the more stable our anaesthesia will be, and the easier our job will be. So in terms of pre-medication, there is no one perfect pre-med for all patients, okay? And the key things you need to think about when deciding on what drugs to use are you need to look at your patient. So how sick is your patient? How stable is your patient? And what is the patient's temperament like? Okay, you're going to look at the procedure, what you're going to do and where, and you're also going to think about yourself, okay? Personal preference and personal experience will have a huge impact on the drugs you select. Okay, and you can pick a whole host of specialist anaesthetists and we will all probably give you a different protocol for the same procedure because our own experiences will have an impact on what we like to do and why. What you have available in your practice is also going to influence what drugs you give. Okay, you can only use the things you have available and your familiarity will have an impact. Sick, unstable patients are generally not the ones to try drugs you have never used before because you don't know what to expect. And if something weird happens, you won't know if it's because genuinely something wrong with your patient or something to do with your drug. It can be harder to define. So when you're thinking about pre-medication, what I would say is the baseline is you are likely to need an opioid. If your patient is painful, you're going to go for something like methadone, buprenorphine, something that will provide decent analgesia. If your patient is not painful, butorphanol may be the right choice for you. Okay, and then on top of that, you will you'll add in other drugs as needed. If you have a patient who is cardiovascularly unstable, who is hypotensive, who is dull and depressed, you are unlikely to want to give a drug like acepromazine, which causes vasodilation, which will increase heat loss, has quite a long clinical duration of effect. You give it, you can't take it away again. And also this patient probably doesn't need that much sedation. And the flip side is again things like medetomidine. In a patient who's cardiovascularly unstable, you may see an increased occurrence of the negative cardiovascular effects of medetomidine, so the decreased cardiac output, the bradycardia. Okay? These patients may not be able to cope with that. You also probably don't need the degree of sedation that those drugs provide. Okay, and you have to think about why you're giving the pre-med. Are we giving it because we actually have to peel the cat or the dog off the floor and we're trying to get IV access, in which case we'll need more sedation? And probably that patient is a little bit more stable cardiovascularly. Or are we just trying to reduce the amount of anaesthetic agent that we need to give to reduce, or induction agent to reduce the negative side effects? If that's the case, maybe start with an opioid and then build on from that.